good one to talk
Yeah,
about.
masking has been one of the number one questions that we've been asked about. Masking, and then also a lot of questions about ADHD and medication. As always, if you have any questions while we're live, drop them in the comments and we'll get to it. But I think we're going to start with masking. So firstly, what is masking?
So masking is a coping mechanism that neurodiverse people use, so both people with autism and ADHD. And it's basically, we were talking about this just before, basically another word that you can use for it is camouflaging, and that probably captures a bit better what it is, which is where you're hiding autistic or ADHD-related traits and presenting as neurotypical. And, it's one that I actually prefer the word camouflaging. We were talking about this.
I love
Masking's
camouflaging.
A bit like it's something that you're taking on and off. And camouflaging's a lot more nuanced. It's something that you can be turning up or down. And I like it as a word better.
Masking feels to me, it feels bad. I don't really like the word. When I consider the thought of am I masking? I don't like it. It doesn't make me feel good. Whereas camouflaging makes me think it's just a more kind of human or natural experience. Yeah. So really like that. A lot of questions that we had specifically about masking was, if you are neurodiverse, how do you unmask?
Yes.
So we'll let Dr. Dom start with, how do you unmask? Because it's actually very difficult. And if you're neurodiverse and you've been masking or camouflaging for your life, it's hard to know how to stop doing that.
And it's a mixed thing because, I guess where we want to just kind of cover before going into how to do it is that it's not just all negative. There are definitely some aspects of it that aren't helpful. And, it takes a lot of energy and effort. And depending on if it's coming from a shame-based place, if it's coming from it is not okay for me to have these traits and they're in some way shameful, then that's really going to be impacting on your sense of self and your mental health. But there are some positive aspects as well. It's kind of, we do live in a neurotypical majority world. And,
hi, Chris.
It's a little bit like if you go to a foreign country, you're going to have to, you're going to work to try and adapt to that culture, just so it helps you kind of, that actually takes less effort at a certain point. So it's very much about looking at where is it unhelpful and where is it actually a helpful thing. And then I guess if you're wanting to have a look, one of the interesting things that I hear a lot of people talking about, and no experience this myself, to a certain extent it does become involuntary. It's not something you can completely control. Once you kind of sit there and start really kind of connecting with that you are autistic or that you do have ADHD, the unmasking just starts to happen. It gets harder and harder.
Thank you so much, Chris.
And the other thing that, I've just noticed happening is even when I've kind of talked about being autistic here, afterwards, parts of my mind started kind of coming up and becoming available. And so that's kind of an internal unmasking happening. But if we want to kind of get to practical skills, if we have a look at what masking or camouflaging is, it's hiding autistic traits. So the very first thing is to get to know your own autistic traits or your ADHD traits, befriend them, actually connect and make them part of yourself. And then you can make a choice how much you want to show them to other people.
How would you say that masking is different if you have an ADHD compared to autism? What do you think happens in the distinguishing between ADHD and autism?
I think ADHD masking is a lot more about hiding areas that you might struggle with. So if somebody's got a lot of executive dysfunction, they'll often be doing a lot of coping things to make sure that other people don't see that, partially because there's just so much moral judgment out there about that area.
Guys, please feel free to drop comments and questions while we're live. We always love questions if you DM them in advance, but we're so happy to... Oh, and thank you for filtering or modding, but we're always so happy to answer the questions live.
Yeah.
This also brings to the ADHD discussion because Dom and I were just talking about ADHD and Dom brought up so many interesting things. So we're going to talk about ADHD and medication, what it is, how it works, but also when it comes to ADHD, masking things that, you're saying you're ashamed of.
Yeah.
I really just wanted to get into the ADHD discussion because Dom told me something really interesting about people having accidental injuries because their ADHD isn't treated. So if you are ADHD and you're having accidents and you're not being, treated or you're not caring for it, this is so important. Are you happy to share that story? Because I found it fascinating.
Yeah, people focus a lot on ADHD from the perspective of capacity to study, capacity to be able to function at work. But a couple of the really big areas that don't get talked about, and the ones that we're going to be looking at about whether somebody needs medication or not, driving for adults, driving. ADHD can really impact on a capacity, and I know people who actually choose not to drive because it impacts them so much. But just simple accidents around the house, and what's often, people kind of underestimate the impact, but there's actually a much higher mortality rate from accident for people who are with untreated ADHD.
This is what blew my mind, a higher mortality rate for people with untreated ADHD. So yes, if you have a child that has ADHD or is neurodiverse, you're much more likely to have it. I'm just going to go back quickly, answer a few quick questions, and then we will get to that. So, doctor, my mouth and body sometimes shake when I get very excited or nervous. Is this normal?
Look, it's one of those things that is very much what the body does. And, it's one of these areas where it's become less and less socially acceptable to have some of these body reactions. And you'll see it, when we move across into autism, where people are stimming, where their excitement and enjoyment will actually come out so physically in their body. And are you okay with that, sharing the story about your little boy? So we had a gorgeous time a couple of months ago where Hannah's little boy was super excited about something he'd just seen on YouTube. He was sharing it with his whole body. His hands were flapping, everything was going, and it was gorgeous. We were just all there, huge smiles on our face. But unfortunately, it's not like that out in general society at the moment. So yes, our bodies probably do want to shake. They probably do want to express our emotions a lot more physically, and it'd be great if society started letting that happen a bit more.
I love it. I think zero judgment. Remember that I'm not the doctor, so this is just my personal feelings, but I love it. And if you're happy and you're excited and your body's showing it, I love that. That's incredible. Another comment was they're 55, so late diagnosed, said one little pill has changed their life.
Oh, yeah.
So that's about ADHD medication.
Yes.
Would love to get into the ADHD medication. So I'll get Dr. Dom to start with listing the main ADHD meds that are used in Australia, what they are, why they're used, how they're effective. So you want to start with maybe the top 3 most common ADHD meds that are used?
So we've basically got, here in Australia, we've got dexamphetamine is the kind of oldest and mainly kind of prescribed generically, so people are calling it Dex.
Yeah, so people won't necessarily know what that is. So dexamphetamine is a stimulant medication.
So I'm just going to be talking right here. We can talk another time about the non-stimulants, but just here we're just talking about the stimulant medication because they're all basically come from an amphetamine base, and they've just got different kind of additives onto their structure.
Now, why would a stimulant medication help an ADHD brain?
Well, we actually know a fair bit about this now, and what happens is we've got a default network, which is the network that's working the way our brain's working when we're daydreaming. Or
Kelso, we'll get to your question as well.
And then if we actually have to go and do something specific, our brain's meant to shift across to turn off the default, go across to a goal-directed network. What happens in ADHD is the default network doesn't turn off, so you end up with both networks running, and this is exactly what people with ADHD, I've got multiple channels running in my brain. The stimulants, we can see it on fMRIs, it turns off that default network, and so the brain looks exactly like a neurotypical brain when we're looking at it, in an fMRI scanner.
Which is so fascinating. Like, I find that unbelievable that you can take a medication and then it will change what an MRI will show.
Yeah, the functional MRIs, yeah.
If you are, so can GPs still not prescribe it? Do I need a psychiatrist? You're in Victoria. I know this is a really massive issue because accessing medical help is really, really hard. So Dom?
This one's all up in play at the moment, and I can't answer it for different states because it's all changing so quickly. We've literally in the last 2 weeks had it announced by the government that they're going to be moving, that GPs are going to start prescribing in Queensland on the 1st of December, but we've also got no information about how that's going to work. So watch that space. There's definitely a lot of pressure. The governments are wanting to move across to it, so see what happens over the next few months there.
There's just a comment here. I'm only 17, and I do just want to answer this because it hurts my little heart. I'm only 17, but I have bad anxiety and my hands are shaking even if all I'm doing is talking to my mum. Dr. Dom deals a lot with obviously people who have anxiety. So would you like to give a couple little immediate grounding tips for people who suffer with anxiety, because it can be so overwhelming?
Yeah.
So if we can just do 3 tips that Dom would say are amazing to center yourself.
And look, very clearly, everything we're talking about here is general information. It's things I'd feel comfortable saying to anyone. It's not specific or actual kind of treatment.
So there's no specific medical information. Obviously, we just have to discuss it generally. But it's just good tips for things that help with people with anxiety.
So with anxiety, you're looking at the part of the brain, it's called the amygdala, is sending off false alarms. And that then goes and talks to your brainstem, which is the part that creates the physical, what we call fight and flight. That's the shaking, the heart racing, all of the physical sensations. And because you've got the physical sensation, then your brain starts creating stories. There must be something wrong. And so the 2 ways you're wanting to deal with it is if it's mainly physical symptoms that you're having, then you're wanting to kind of work with calming the physical side of your body.
So if you've got the hands shaking specifically, things like that, heart racing. I've had many panic attacks. So please don't feel ashamed of it. Take
the focus off whatever it is, the area that's most distressing you, and bring it to another area. So if your hands are shaking, then go across to focusing on your breathing instead. If your breathing's really tight, then work on grounding down. So what I'm talking about when I'm talking about grounding is where you kind of really start thinking about the physical sensation of your feet. Like literally grounding down onto the ground.
Literally touching grass.
That works so well.
Touching grass for me, huge. Actually physically put my feet in the grass. Another one that I personally love is ice.
Oh, ice will absolutely. So
ice is like you're so welcome, Eliza. You're so welcome. Ice, I love it.
Ice works because it's hypersensory, so it kind of overrides, and your nervous system kind of it's almost like a switch for it.
We've also got some comments, and this has come in quite a bit actually. The overlap when we've got CPTSD and neurodiversity. So Dr. Dom and I have spoken about this before, but CPTSD is complicated. So I think firstly we'll get Dom to say what that is.
Okay.
And how that can be caused, and then we'll talk about that overlapping with neurodiversity. So CPTSD is Dr. Dom. What is it?
Complex PTSD. And what that's looking at is, so we tend to think of PTSD as being caused by a single acute severe trauma, so a major accident or, some kind of assault.
Chris, you're just so divine. Thank you.
What we see, though, that's probably the more common is where people have experienced chronic micro traumas or sometimes major constant traumas, often at the hands of
I'll get to that other comment. I'll get to these comments.
Or adults who are have got a lot of power in their environment.
Hi, Ella.
And it's going to have a very different impact on a person's nervous system. And it's also, with complex PTSD, there's the 2 sides of it. It's the PTSD symptoms where your nervous system is still responding as if you're not safe. But it also affects how much, learning the everyday skills, learning emotional regulation, learning the social skills.
I think the concept of the constant micro traumas, I think really hits in for a lot of people, because I think that often we're not aware when you experience them. But if you are neurodiverse and you're having social interactions every day and you're feeling othered or you're feeling excluded, it actually has a very severe impact on your brain. And so that can, you can see how that happens.
And that's then where we bring in
We'll get to that as well, Ella, the loss of skills,
relating the complex PTSD and the autism diagnoses, or ADHD. We used to be trying to divide out is there attentional problems due to complex PTSD, or is there ADHD? What we've realised is that it's often about it both being there, and there's increasing. Just the science is just starting to come out on this one, that I'm looking more at the autistic neurotype.
So glad, Ella.
That there's actually kind of possibly changes within the autonomic nervous system that makes people with an autistic neurotype more likely to develop PTSD.
Yeah, that's really interesting, because obviously we've also been having a lot of discussions about things like POTS. We're not going to get into that today because that's a much deeper and big conversation. So we absolutely will get into those things and the overlapping of multiple diagnoses with neurodiversity. But I just want to answer some specific questions while we were going through them. So Jordan, because again, this is a really common one. Jordan, how do you deal with social anxiety and dealing with fight or flight level stress? So again, this was the grounding, and I think that's a really good thing to talk about.
So grounding is where you really work. You actually kind of bring all your focus down to your feet. How do they feel? Pushing them into the ground, preferably if you're on grass, something where you can really feel it. When I'm doing it in my office, I've got this horrible concrete floor, but it's really great for grounding because it's really hard and you can push into it and it gives you that support back.
Concrete? You like a concrete floor to ground into?
Well, it works. It works really but it's anything that's going to give the sensory sensation but also that physical support. And what that does is actually sends messages back up the vagus nerve that you're safe, and it starts to turn off the fight and flight. The other one, if you've got access to it, is any of the breathing exercises.
The breathing's great.
Yeah. Big thing with breathing, if you're already in fight and flight, is breathe out before you try to breathe in.
Which is so difficult, by the way. If you struggle with this, you are not alone. It's so hard because for me personally, panic attacks, I feel like I can't breathe and I'm choking.
Yeah.
We're not going to be answering that specific question, but I just wanted to go back to another question because this relates to the overlap of if you're a parent with a neurodiverse child, what's happening when you get a late diagnosis. So Dom, what do you think the current kind of statistics are if you have a child that's neurodiverse? What percentage of the parents are then also presenting as being neurodiverse? Thank you, Chris.
I'd be really interested to know what the latest figures are on this one. The figures for prevalence are changing year by year. We were listening to that New York Times podcast.
New York Times pod was great. Listen to the Daily a few days ago. Really good if you're interested about autism and prevalence. Really good.
But the prevalence rates are just going up every year, so it's very hard to kind of what are they right now. What we generally find is that if we've got a child or young adult who's presenting, then one or both of the parents are going to, be neurodiverse, most of the time. It's not always. But when we're talking about neurodiversity, I guess we want to kind of bring that in a little bit as well, because there's two different ways of thinking about it. One's the medical. One's that you get a diagnosis of ADHD or autism or ASD. But there's also, what's been going on in a parallel kind of movement to the increase in medical diagnoses is the neurodiversity movement, which is looking to really demedicalise a lot of this area and looking at neurodiversity as a difference. And that then brings in a whole cohort of people who wouldn't necessarily get a diagnosis but have experienced life as a neurodiverse person.
If you're we can talk about personality disorders and things like narcissism. It's a massive issue. I know people are talking about them. It's huge. We'll just do one kind of quick wrap up on parenting and neurodiversity just because it's huge and it is resulting in a lot of people getting late in life diagnoses. Yes. I have experienced this in real time, which is why it probably hits me. Yes. So has Dominique. So we both have children who are neurodiverse, and then Dom and I both received late in life neurodiversity diagnoses. Very, very common. Very, very helpful
Yes.
It really just it's really life-changing, I would say.
It's a lot to get a late diagnosis. It's very, very different. We are so hopeful for our kids.
Absolutely.
They're just
it's a
coming
different
up with
world.
a very, very different experience knowing from the beginning.
Ree, I would like to answer this because this is interesting and it kind of gets into the concept of the medicalization of neurodiversity.
Yeah.
But so Ree has said, what is your thoughts on a child being 1 point less than required on the autism test? Because again, they do,
this one breaks my heart. It is such a challenging area at the moment, because diagnoses are linked into supports, they're linked into funding.
Yep.
And the diagnoses themselves, literally on the podcast I was listening to last night, they have changed dramatically over the past 30 years. They're almost certainly going to change again in the near future, and there's lots of kind of meetings and stuff like that about what might diagnoses look like going forward. But in the present, diagnoses are being made to very specific criteria. And in Australia, our funding is via a thing called the NDIS, and up till recently, you had to be level 2 autism to get. If you were level 1 autism, no funding. If you were level 2, suddenly you had access to everything you needed. And it just doesn't make a lot of sense.
I also find it very heartbreaking, especially when you're trying to just access support for your child, for yourself, or whatever. It is, and obviously you do need, there's practical elements of getting funding that we do need, but it's so it's so complex, and I guess heartbreaking. I think this would actually kind of follow nicely into a discussion about if you haven't received a diagnosis but you would self-identify as neurodiverse for whatever reason. Right. So, okay. So thoughts on, which I think will just tie into this, self-diagnosis, online diagnosis. What do you think about these things, Dr. Dom? What do you think about it? Do you think that it's important for people to be able to kind of think of themselves in that way? What's your general,
Well, I think, like I was saying, at the moment we've got two different ways of conceptualising it. So we've got the medical diagnosis side of things, and then we've also got the neurodiversity side, which is non-medicalised and doesn't require a diagnosis per se. One of the interesting things, to talk to anyone who's late diagnosis neurodiversity, one of the almost defining points is the do I, don't I ruminations and the imposter syndrome.
Imposter syndrome. Am I faking it?
This?
I have thought that so much. I'm like,
am I using it as an excuse to cover up all my?
am I faking it? Am I autistic or am I faking it?
Yeah, and
no, you're not. You're not faking it.
I was reading something just yesterday that it was kind of like it's so universal. It's almost diagnostic in itself that if you're doubting whether you have it, and all that back and forth as to of course. Look at all these different things. Oh no, I couldn't possibly be.
I literally spent so long, probably a year, thinking to myself, after my psychiatrist had said, you're autistic, I spent about a year going, but did I fake it? Did I fake convincing her in some way? No. Then I took a little bit of a deeper look at my own life and realized, okay.
So from the point of view of self-diagnosis, it's very much recognised within the community at the moment. It is not easy. It's expensive. To get a full formal diagnosis in Australia is anything from $1,000 to $3,000.
Good Lord.
And there are major waiting lists. And often the people who are on the waiting list, some of them are going to be, needing to get that diagnosis for resources or for school accommodations and stuff like that. It's a really tricky area. From the point of view of the online assessments, they've become, it's again that bit of a balance at the moment. The waiting list to get in-person assessments.
Thank you so much, Chris. You're divine.
Leave people for a very long time without treatment. And that's where the online services have become available. There's obviously concerns about, are some of those services
disingenuous
Well, are they just being as rigorous about,
Yeah.
you know, whether people need medication or, you know, do they have the diet? You know, there's a bit more pressure.
Emma, I'm so glad that you've asked about dexamphetamine again, because that was actually what I wanted to loop back to. It's sometimes hard for me to stay on topic and I'll jump all over the place, but I did want to get back to that because Dr. Dom was just talking about it. So thoughts on dexamphetamine for ADHD. Now, so Emma, we can't answer any personal questions. So I see you're 17, already suffering with depression. We won't answer personal questions, but we'll explain what dexamphetamine is, what are the brand names in Australia, and why would it be prescribed to people.
So dexamphetamine, so of the different stimulants, we've got dexamphetamine, Ritalin or methylphenidate is the generic name, which is the chemical name. So one's a brand name, Ritalin's the brand name, methylphenidate's the chemical name. Then we've got Vyvanse, which is the brand name, or lisdexamphetamine is the chemical name. So dexamphetamine was the original stimulant. It's the one that we've had the longest and most experience
We'll get
with.
to side effects as well, Emma.
It's only got a short-acting formulation, so it acts for 3 to 4 hours. And it's, you know,
I'm so glad,
a
Tony.
lot more people are going to find it a bit rougher from side effects. Some people find it's exactly the right drug for them.
Is there an anxiety roll-off? That's what I've been told about some of these stimulant drugs, that they get anxiety roll-off.
There is.
Okay.
And it varies between them. Less likely with the short-acting drugs, more likely with the longer-acting drugs.
Right.
And I'm definitely getting reported more with Vyvanse, where they're geting anxiety or irritability.
Now, Vyvanse
So when
is
we're talking about the roll-off, sorry, I'll just explain what that is.
So, sorry,
So
guys.
these drugs, they're only working when they're in your system. They're asymptomatic. You know, they're not changing the underlying function. So they're either there and working, or they're worn off and they're no longer having any effect. And so people will describe very much the onset, where they can feel the drug coming in and their attention becoming available to them, and then the offset when the drug wears off. And that's the, you know, where people can sometimes find themselves getting a bit irritable or anxious. But one of the great things, because we've got the range of different medications, often by the time we try between, you know, start a person on one of them, then shift across to one of the others, we can find one that fits each individual person.
Yeah, it might not be, I think, you know, I've spoken to a lot of people who have ADHD. Obviously, I'm very entrenched in this world because I have a child with it, and it does take some trial and error for people. So we've got 2 comments that I want to get to. One person who was saying, is it a concern that if you're prescribed a stimulant that it's going to affect anxiety or depression? Then we had another comment saying that they found it's helped their anxiety.
Yeah.
So thoughts on that, Dr. Dom?
Yes. So one of the features of, you know, people experience with ADHD is that they have a lot of difficulties with emotional regulation. You need to be able to hold your attention on what's going on in your body or what's going on with the story in your mind to be able to then regulate your emotions. If you can't do that, then, you know, you're going to really struggle with that. So we do find that the treatment medications actually help people be able to pay attention enough to what's going on with them to then regulate, their emotions more. And there's anecdotal, that means that we see it a lot clinically, that some of them actually seem to have a specific effect with emotional regulation beyond just the attentional effect. Yes, so, but they are also stimulants. They will increase your alertness and your attention. And for some people, they'll find that actually makes them more aware of what's going on in their body, if there's anxiety there, or make them feel edgy or agitated. And then it's about finding the right dose or the right particular medication.
Now, what about things like medication overlaps? So we've already spoken about the overlap of other conditions with neurodiversity.
Yeah.
So if people have ADHD, then they're looking to take a stimulant medication. What's your thoughts on medication overlap? So people are taking antidepressants, for example.
Yeah. So I will just comment from the point of view of different conditions. So there is one condition which is, psychosis or schizophrenia.
There were a few questions about that as well. Yeah,
where it's almost, the stimulants are likely to make that worse. and it can even cause psychosis in some people. So that's actually one of the rare but very, very serious side effects of these medications. So that's a particular diagnosis that would need a psychiatrist involved, and pretty well means we can't prescribe the stimulants.
Yeah.
From the point of view of the other areas, anxiety, depression, the stimulants can be used with antidepressants. They don't interact, the two drugs don't interact, and we often have people on both.
So yeah, I'm seeing a lot of questions about specific medications, their overlaps, and how they might interact. We will probably do next week's live and get into that in a deeper way, just because it is really complicated and obviously we can't give anything specific. So we're just going to stick to kind of the general discussion for now. There was a separate question, not related to neurodiversity, but another kind of thing that has come up a lot. Relating to interpersonal relationships, someone had a question about anger and managing partners' anger.
Oh, gosh.
I think managing anger is a really important one to talk about.
Yeah.
You comfortable talking about managing interpersonal relationships with people that are angry? How would you, what do you think about it?
Let's start just talking about emotions, in general, because as a society where, there's a lot of thoughts within the mental health world that we're not doing, the best that we can with emotions in general.
Yeah.
There's been a real focus in using thinking and using cognition and seeing our emotions as something that are a little bit troublesome or that we need to control. And, when we look at the way that the mind works and the complex system that it is, emotions are an immensely important part of our experience and, about how we actually get, they're information that we need. And, of all of them, anger is one of the ones that both is avoided a lot, or the other way is that people aren't taught how to regulate it or to manage it. And it's a really hard one, if you're seeing it in your partner as well, because depending on what your experience has been, then, can throw people into kind of full fight and flight or shutdown, which makes it really hard then to respond to that anger. And when people are, if they've allowed their anger to get to the point, it can really stop them being able to think clearly as well. So, they're caught in the emotional storm that makes it very hard to then for both people involved.
And my heart just goes out to you if you're dealing with that, if you're dealing with a partner that's having these episodes, and it's amazing that you want to help them. Remember that I'm not a psychiatrist, so I'm just giving my opinions. My opinion is just always keep yourself safe and take care of yourself.
Yes.
Yeah, so Roxy, I'm sorry you're dealing with that. And just take care of yourself and you're doing amazing. We've had more questions, Storm, about adult diagnosis of ADHD.
Yes.
So, anger. Yeah, we've got more anger questions.
Yeah.
I think we'll probably dedicate a bit more time to that next week. We'll do now quickly what is involved in an adult diagnosis for ADHD, and then we'll do a really quick discussion about some personality disorders, if Dr. Dom's happy to go with a little bit of that. But so adult diagnosis
of ADHD. One of the things, again, we come into, if we're looking at diagnoses, then we have very specific criteria, and which are the rules that we have to use to make a diagnosis. And these are even more in place for ADHD, because if we make a diagnosis of ADHD, often it's with the expectation of using stimulant medication. There's a whole heap of laws and regulations about them. They are managed differently to other medications. So one of the big criteria that can be challenging relating to an adult diagnosis of ADHD is our criteria involve being able to show evidence that the condition was present prior to the age of 12.
Right, so it has to be prior to the age of 12. Yeah, okay.
And that's actually really important, because nowadays we are seeing a lot of secondary attentional problems. And I don't know many people out there, myself included, who aren't struggling with attention and concentration. And the stimulants are only going to work for people who've got the actual neurobiological differences in their circuitry. So one of the things, if you do go and go for an assessment, you're going to generally be asked to try and get some information, whether it's school reports. And the great thing now, most school reports have been computerised, and we can get the schools to go back.
We just had a comment saying, how is it possible if I'm 35 to prove that this was, happening when I was a child? But
you'd be surprised how often school reports are still in somebody's basement, or the schools actually have them on computer. The other one is that we need to get information from parents or family members and actually, get them to say what did they see about the person.
Right.
Which, sometimes that's easy to do, sometimes that's a little bit more challenging.
OCD, actually, do you want to talk about OCD quickly, Dom? Because that's kind of falling into the neurodiversity discussion.
Yeah. So OCD is obsessive compulsive disorder, and there's what we see is there is a very specific condition called OCD, which often people start developing around the age of 8, can develop at other times in life, where they get very specific, either specific episodes of or continual experiences where they get the obsession is the thought. So the current, the classic ones people know about, the germs or the, hand washing. Hand washing,
flicking lights is something that,
feeling like you don't get that sense of completion when you turn a light off.
Sorry, Kimmy.
And then the compulsions are the behaviour that you do to take away the distress associated with the obsession. So that's actual OCD, which is a very specific condition. But then we've got a lot of people who will experience obsessional thinking as part of their neurotype, and then particularly as part of autism, the autistic neurotype's got a lot of obsessionality in the thinking, but it often occurs outside of that as well.
Me.
Some people will develop, this is actually one of mine, if I get stressed enough or if my brain is exhausted, I'll definitely get into checking and stuff like that. But it only happens, when my brain, there's something going on. If you're exhausted. With exhaustion.
Yeah.
Which is a little bit different to the full disorder.
I'm seeing so many comments about people who are struggling to get diagnosis and to get access.
This one's huge.
Yeah.
This one's enormous, and, there's a lot at the moment trying to work out what the best way to go forward is. We know that the prevalence is up. We know that the number of people who did not get diagnosed as children and who are now being identified, and how do we work through that? And it's a bit of a balance, because this is a really serious condition, and these medications, you're on them long term if they work for you and you start them. And, they do have some serious side effects, and they do have some, nuances to managing who's, what's the best one for different people.
Yeah.
But at the same time, it's restricting diagnosis just to psychiatrists has meant massive blowouts in waiting lists.
So people can start with GP to get referrals to psychiatrists.
At the moment. In, like I said, Queensland has just in the last week announced that they will be moving across to having specialised GPs doing assessments, but we haven't received any details about what that's going to look like. And, they've said, the GPs they'll only be able to do it if they've got specialised training, but they need to get specialised training in 2 weeks. So I don't know how that's going. I'm assuming there will be a bit of a lag in that occurring. I think New South Wales might have already started GP assessments. I can't talk about the rest of the country.
Can you quickly touch on, I've just seen a question that, do you feel that young boys specifically are being misdiagnosed? So do you think there's a lot of misdiagnosis happening, which I guess this ties into the prevalence issue, and this is an evolving state of affairs. It's really hard to know right now what the prevalence actually is. So...
And look, I'm a general adult psychiatrist. I just work with adults. I don't do any assessments of children, and definitely not up on the prevalence and what's going on with the diagnosis. I do have a little boy who was diagnosed quite early. He was 4.5, I think, when he received a diagnosis, and has done really well on medication. it's it is very much about having a look. Boys are more active in the classroom. They are going to struggle more with the structure. There are big differences, especially early on, that kind of 5-6 age. Girls are developing neurobiologically at a very different trajectory to boys. They're going to be ahead on academic capacity, not because that's going to be the way it is long term. It's just the different developmental timings. And, it is a really important one that we are thinking about, letting boys be boys, letting boys have the activity they needed and not medicalising that.
Dom, just because I've seen this one come up multiple times, ODD.
Yes.
ODD. Can you explain that a little better in combo with ADHD and ASD?
Okay. ODD is oh gosh, I've just gone completely blank.
I know.
Oppositional defiance disorder.
Yeah, oppositional defiance disorder, yeah.
This is one of those interesting kind of areas, because
Anxiety.
sometimes in psychiatry...
Sarah, we'll go back to anxiety in a second, but
we're seeing people presenting with very similar presentations, and we don't really have a good idea of what's going on behind that or why it's occurring, and that we then create a label so that we can start actually, trying to make sense of it or try and work out what it is that we're looking at. And ODD is one of those. So it's where, it's diagnosed very much from a particular behavioural program, kind of profile. And it's a real challenge dividing out where ODD is present, where the behaviours have a lot more deliberateness to them. Like when we're using the word defiance, it has a sense of the child having more intent or awareness related to their behaviours, as versus ADHD, where you're going to see a lot more where the kids, yes, they are struggling with regulation, but they truly have no control over that in that moment.
Neurodiversity and a strong sense of social justice. Absolutely.
Yes.
Absolutely.
That's one of the bonuses. That's one of the superpowers of it. Definitely.
Absolutely.
Yes.
I think
it's one of the things that's probably most universal. That when you talk, there's so many things that are different between different neurodiverse people, but I mean, sense of social justice, and it's powerful and it's
amazing.
It does make life, it does make it hard to live with a lot of what's going on in the world.
Courtney, I'm not sure what FND is.
It's a functional neurological
disorder.
And
traumatic childhood. So the concept of nature versus nurture is a big one. And also just quickly for another one on the ADHD, if you are neurodiverse and ADHD, it's not something that you will develop and yo-yo in and out of. It's your brain for your life. So no, it's not going to wear off. That's what it is.
It's the way that your brain wired during neurodevelopment before you were even born. It will vary according to different environments. It will vary at different times in life. There's a big onset for women in menopause.
Really?
As the hormones drop off, a lot of women they've always had ADHD, they've had the neurotype, but it becomes much more apparent and obvious.
Yeah, so I think that's probably a really good insight that it's your brain. It's not going to change, but symptoms might change. Yes. Severity of symptoms might change.
And on that particular one, just an interesting one for ADHD and women with ADHD is we do see changes across the menstrual cycle, both in the amount of symptoms and the effectiveness of medication. So that one's real.
And like PMDD is more common if you're neurodiverse.
I'm just seeing ADHD and menopause is hell on earth. Absolutely. Yes.
Absolutely. And don't get me started on medical misogyny, that women have not been studied and our bodies have not been studied, that we've just been like, they've run tests on men and tested medication on men, but women's bodies are completely different. I could go down this rabbit hole, people. I will try not to. Because we've had a lot of questions, so many about narcissism and BPD. I'm going to get Dr. Dom to quickly say, what is narcissism? What is BPD? And then we can talk about some more specific questions. So, narcissism.
is a particular style of interpersonal relating. So there is a thing called narcissistic personality disorder, which again goes into a more medicalisation, but narcissism is a way of relating to others. And it's definitely increased in prevalence, and that's why we're seeing it talked about so much. It's where a person's got an inflated self-esteem and it's got that grandiosity to it. It's the theory behind narcissism is that there's a very fragile ego sitting underneath that kind of superficial kind of grandiosity. And what that means is, people who are coming from a narcissistic kind of approach they're desperate to protect that fragile ego, and they will use pretty nasty tools, the manipulation and the denigrating.
Is lying a part of narcissism?
It definitely, and lying's an interesting one because is it conscious or unconscious?
I'm grabbing a lip balm, everybody. I'm so sorry. I'm just grabbing lip balm. Yeah, narcissism. Yeah, okay.
Yeah, I like to talk about the idea of the stories that we're telling ourselves in our heads, because we all do it. We all create stories in our heads about a particular experience we've had or the way we're viewing that, and everyone's stories are different, and that's just being human. But what you will find is that the narcissist's story will always have themselves as, the kind of superior, and their story will be much more entrenched. And then, there's that, are they comfortable actively lying, deliberately lying versus, getting so caught up in their story.
So do you think that narcissists, this is, again, generalizations, we're just talking generally, but would you say that narcissists are they aware they're lying? Do you think that they're aware they're lying? Or do you think that they're believing their internal,
It's a mixture of, yes.
My general observation would be, if you think that someone in your life is a narcissist, stay away from them. They're not worth your time. Please leave them. Run away from them.
And I
Angie, love
that one, but I'm also coming from the every single human needs support and help, and
Dr. Dom is much kinder than I am,
and unfortunately with the narcissist, the more we isolate them, the more harmful and they become. But it's also about not enabling them or allowing them to do others.
Damn it, you're such a good person.
There's
Dom.
a guy called Terry Real.
She's a much better person than I am.
There's a guy called Terry Real, and just to be clear, whenever I talk about a reference or refer to somebody, it's because I've felt that it's not kind of promoting them or anything. It's very much, I think that they've got something that's really helpful and really accessible. Terry Real's a family therapist who's written a book called Us, which is I've just started reading it, and it looks like it's going to be really helpful. But he's had some of the more helpful things to say about narcissism and looking at how to manage them. And he uses an analogy of a torch.
Can you just say his name and the book title again? So it's called Us?
His most recent book is called Us, but his name is Terry or Terrence. Sometimes he goes by Real, Real.
Do you want a drink?
I've got one.
Yeah,
I'm good.
Yeah.
So he actually looks at it very much as the narcissist constantly trying to kind of shine the torch and get attention, and his answer is just to take the torch off them, take the attention away from them. So
do you want to do BPD
very briefly, and then we might get close to, we'll just check what else we've got. BPD, borderline personality disorder. This one's got a lot more kind of history to it and a lot more complexity. This was in the past. This has been a diagnosis that was used.
I'll get to Sapphic, your question next. I'm just going to write it down quickly. So Dom's going to go through BPD a little bit more.
So BPD is a type of personality style where there's a lot of instability of sense of self and emotional dysregulation, and it can create a lot of difficulties in interpersonal relationships. But the idea of that particular term, for a very long time before we started talking about things like complex PTSD, it was a term that was very much used to to say that traumatized women make them responsible for their trauma, basically.
Chris and Safik, we will answer that question.
Of what had happened to them. Nowadays, there's been a real kind of realignment with that and a real understanding of how much trauma impacts on people. And but what's really interesting is BPD is actually coming back up again, where younger people are reading about it and realising it can actually be a really helpful way of them making sense of their experience. And we've got really good treatments for it now, which is a thing called DBT, dialectical behavioural therapy.
Angie, could you just drop your comment in, could you drop your question in the comments for me? Because no, we haven't covered it yet, but could you? So we're going to get to Safik's question because this is great. Alternatives to medication. People want to know what you can do as an alternative to medication. So do we want to talk about neurodiversity or do we want to talk about anxiety and alternatives to medication?
Well, it's about working, with definitely when I'm working, depending, I'll be very much looking at where and why are we using medication and what are the alternatives. Because medications, for sometimes it's absolutely necessary and it can actually augment and help people get into a place where they can actually access the non-medical things, the therapy side of things. When we're looking at what can you do for,